Hello, my name is Ayana Fredericks, and I am a graduate student at the Chicago School of Professional Psychology, DC campus. The behavioral addiction that I will be presenting is shopping addiction, which is more formally termed compulsive buying disorder. Here is a presentation slide which serves as a table of contents for the presentation to come. Shopping addiction. According to Donald Black's 2007 article, compulsive buying disorder, or CBD, is characterized by excessive shopping cognitions and buying behavior that leads to distress or impairment. CBD was first described in the early 20th century by Emil Kraepelin and Eugen Bleuler. The diagnostic criteria for compulsive buying disorder was first proposed in the year 1994, which was then later refined. However, this disorder is not yet represented in the Diagnostic and Statistical Manual or International Classification of Diseases classifications. LaJoyo and Weinstein, 2010. The case of Ryan. Ryan is a 49-year-old divorced father of two. He works as a manager for a local retailer. Though he has always enjoyed browsing at stores to see how they're set up as compared to his own, he has discovered that he enjoys finding a good deal on an item even more. He will look through the Sunday newspaper for sales flyers and price compare to find the best deal on an item, then go purchase it. His daughter asked him one day why there were so many bottles of shampoo in the closet, and he responded that they were a great deal, so he stocked up. Ryan finds that the better the deal, the more he enjoys the purchase. He has resorted to buying things he doesn't need just because they are at a good price. Because of the questions his children have been asking, he has been hiding these items in his closet, intending to return them eventually. However, he does not get around to doing so. He has more recently hit the credit limit on his credit card due to these purchases, and he is concerned at how it will impact his ability to take advantage of the good deals he finds. Without available funds to purchase items, Ryan has been stealing small things from stores in order to not draw attention to himself. But he's not stealing out of necessity. Cognitive behavioral therapy. The Capuzzi and Gross 2011 text has it that cognitive behavioral interventions include various combinations of cognitive and behavioral techniques and are aimed at changing either cognitions, behavior, or both. The text also holds that Aaron Beck was the founder of cognitive behavioral therapy via his research with depression and cognitive therapy. These interventions are directive, structured, goal-directed, and time-limited treatments, according to Capuzzi and Gross, 2011. Sessions usually last for about 3 months and can be 50 minutes each. These interventions have been used with clients from numerous cultural and ethnic backgrounds within the past decade especially. This therapy is said to be used with clients with a variety of common disorders, for example, anxiety, depression, and addiction. These interventions have been used with clients from numerous cultural and ethnic backgrounds within the past decade especially, according to Capuzzi and Gross in their 2011 text. Additionally, behavior therapy has the potential to be dehumanizing. Techniques can be perceived to be sterile, standardized, and mechanistic. Cognitive behavioral therapy may lack the promotion of internal growth in clients, and there is a lack of one specific behavior therapy to guide counseling. And those represent cultural considerations and risks and cons. Dialectical behavioral treatment. Marsha Linehan is the founder of dialectical behavioral treatment, or DBT, according to Capuzzi and Gross in their 2011 text. Dialectical behavioral therapy is a hybrid form of cognitive behavioral therapy, which merges cognitive behavioral therapy with Buddhist mindfulness-based practices. DBT is a combination of individual counseling and concurrent skills training, such as mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance, according to Capuzzi and Gross in their 2011 text. Demeth and Linehan, in their 2008 article, classify the target population to be individuals with multiple and severe psychological disorders, chronically suicidal individuals. Capuzzi and Gross in their 2011 text suggests that individuals with self-injurious behaviors are the population this approach is often used with. It is common that these individuals have borderline personality disorder in conjunction with substance use disorder. In DBT, the counselor takes ultimate responsibility for developing and maintaining the treatment plan for the patient. The goal of this treatment is to encourage clients to both accept themselves and to change their behavior. This is all according to Demeth and Linehan in their 2008 article. According to Capuzzi and Gross, the client commits to participation and works toward maintaining treatment goals. This was said in their 2011 text. Dialectical behavioral therapy was not designed to be a brief intervention. Clients commit to 1 year of treatment. This year of treatment consists of weekly psychoeducational skills training groups, weekly sessions with an individual counselor to identify and reduce factors that interfere with the ability to use skills, and telephone contacts with counselor on an as-needed basis when crises arise. This is all in accordance with the 2011 Capuzzi and Gross text. In this same text, it is also said that there is much empirical evidence which suggests that dialectical behavioral therapy is best used as an outpatient treatment in urban settings. However, both systemic and cultural adaptations will need to be developed for use with populations beyond borderline personality disorder and outside the United States of America. This approach is highly structured and specific, and it does not fit all populations. Ethical considerations. Professional counselors, regardless of specialization, must be sure to adhere to the basic moral principles and the ethical guidelines of their respective professional organizations and certification boards and or agency of employment when practicing. This is information that is taught to upcoming counseling students. The moral principles a counselor must always strive to apply in session and in the treatment of clients, regardless of theoretical approach, are justice, beneficence, non-maleficence, autonomy, fidelity, and veracity. This is all in accordance with Stevens and Smith 2013 PowerPoint. The Association for Addiction Professionals, also known as NAADAC, promotes the notion that personal and professional ethics cannot be dealt with as separate domains in their 2013 posting. Appropriate assessment tools. Two assessment tools which are appropriate for assessing individuals with compulsive buying disorder are the Yale-Brown Obsessive Compulsive Scale, shopping version, and the Canadian Compulsive Buying Measurement Scale. The Yale-Brown Obsessive Compulsive Scale, shopping version, was modeled on the YBOCS, which also stands for the Yale-Brown Obsessive Compulsive Scale. The most recent version, which would be the shopping version, assesses the severity and interference caused by buying thoughts and behavior rather than assessing obsessions and compulsions. The instrument is reliable and valid in measuring severity and change in persons with compulsive buying disorder. This is all in accordance with LaJoie and Weinstein's 2010 article. With regards to the Canadian Compulsive Buying Measurement Scale, this scale is a 13-item scale which explores three basic dimensions. These dimensions are the tendency to spend, a reactive aspect to triggers which may lead to shopping, and post-purchase guilt. LaJoie and Weinstein in their 2010 article cited Valence et al., who found a statistically significant difference between the addictive buying averages of a general pool of consumers and a second pool of compulsive consumers. Appropriate assessment tools continued. LaJoie and Weinstein, in their 2010 article, stated the following with regards to self-report assessment tools. These self-reported ratings and semi-structured interviews cannot replace clinical evaluation. Clinicians must inquire in detail about buying attitudes, the extent of preoccupation with buying and shopping, urges to buy, feeling and thoughts associated with buying, and the interference with social, financial, and occupational functioning. Level of care. The American Society of Addiction Medicine has a set of criteria that is widely used by professionals to determine the levels of care needed for treatment of individuals. More specifically, In accordance with ASAM's 2015 document, the criteria provides treatment professionals with objective standards they can use to help identify the least intensive treatment services that can help keep a participant safe as he or she works to make personal life changes. Additionally, ASAM uses a multidimensional assessment for the purposes of gauging how treatment might affect multiple life areas of an individual. These criteria look at 6 major life areas or dimensions to achieve this. The 6 dimensions, according to ASAM's 2015 online document, are acute intoxication and or withdrawal potential, biomedical conditions or complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use, or continued problem potential, and lastly, recovery environment. Although there are assessment tools that have been identified as being appropriate for Ryan's addiction and addictions in general, Ryan has not yet undergone any formal assessment. And in keeping with ASAM's criteria, that is a key component of determining level of care. There is also not enough information yet gathered about Ryan to complete ASAM's multidimensional assessment. With these things being the case, Ryan's current level of care is 0.5, which is early intervention. This level of care, according to ASAM, entails assessment and education. Now, this is most likely not what is the level of care in reality where Ryan is concerned. However, given the limited information, if a level of care were to be assigned to Ryan with what is currently known, it would have to be a 0.5 early intervention due to the fact that no assessment has been done. Relapse prevention plan. The prevention plan that has been identified for use and application with Ryan is Marlet's RP model. According to Hendershot et al. In their 2011 article, relapse is described as a hindrance that occurs when an individual is trying to alter a behavior. Clark and Kalija, in their 2008 article, cited Marlet et al. 1988, page 224, where there was an expression of the notion that individuals attempting change behaviors, whether through treatment or self-initiation, are usually marked with a high relapse rate. Marlet's RP model provides a framework that helps individuals understand relapse, as well as providing a set of treatment strategies designed to limit both the likelihood and severity of relapse, according to Hendershot et al. In their 2011 article. This model does not view a relapse or a return to the undesirable behavior as the failure of treatment, but as a mere lapse or setback in treatment, according to Hendershot et al. 2011. This is a very hopeful way to encourage an addict to view and conceptualize the status of their addiction treatment. This leaves room for growth. This leaves room for steps back with the understanding that it is possible to still move forward and surpass progress once made. Using Marlet's RP model in Ryan's case, Ryan and the counselor would identify specific high-risk situations to help enhance Ryan's skills for coping with high-risk situations. Additionally, as part of Marlet's RP model, Ryan and the counselor would work on increasing his self-efficacy, eliminating myths regarding spending's effects, managing lapses, and restructuring his perceptions of the relapse process. This information for conceptualization was provided by Larimer et al. In their 1999 article. Relapse prevention plans serve the purpose of aiding clients with maintaining target behaviors during treatment and providing the tools necessary to help a client get back on track with treatment when a lapse occurs. In Ryan's case, there would need to be a series of steps mapped out for when a setback occurs to help him get back on the right track. Diagnosis. Black, in his 2007 article, proposed 4 criteria for compulsive buying disorder. Compulsive buying disorder is Ryan's primary diagnosis. These criteria proposed by Black are anticipation, preparation, shopping, and spending. Ryan meets these symptoms due to a preoccupation with good deals on purchases, preparing for purchases by comparing prices at different locations, going and purchasing the item for the best deal, and hiding the items in the house once purchased. These behaviors are all in line with the clinical symptoms proposed by Black in his 2007 article. Internet gaming disorder, or IGD, is included as a condition for further study in the DSM-5. As a result of compulsive buying disorder not being in the DSM-5 or in the ICD, Internet gaming disorders severity scale will be applied to Ryan with his compulsive buying disorder diagnosis. For IGD, the degree of disruption of normal activities is what determines the level of severity, according to APA in their DSM-5. Ryan should be assigned moderate CBD due to there being no indication of loss of employment, no incarceration, and no outright monopolizing of time spent pursuing good deals. Mild is ruled out due to there being significant disruption of life via potential financial risks and the exhibition of all specified criteria. Earlier in this presentation, I mentioned that compulsive buying disorder is not represented in the diagnostic and statistical models or the international classifications of diseases classifications. According to LaJoie and Weinstein in their 2010 article, the DSM-5 task force proposed 2 important changes related to compulsive buying specifically. One of these changes was to create an obsessive compulsive disorder spectrum and to create several new autonomous disorders from those currently described as impulse control disorders, not otherwise specified. Among the new autonomous disorders would be compulsive impulsive shopping, CI shopping, and compulsive impulsive or CI sexual behavior, to name a few. This development would allow for the inclusion of other process and behavioral addictions in the diagnostic and statistical manual. So this is definitely a positive development. Moving on to the final piece of this presentation, the DSM-5 diagnosis. The previous diagnosis was not one that could be found in the DSM-5. With this having been the case, a possible diagnosis proposed for Ryan that can be found in the DSM-5 is obsessive compulsive disorder with absent insight or delusional beliefs. 300.3 F42. Now, when comparing Ryan's symptoms to the criteria for OCD, there is definitely distress caused by Ryan's obsession with quote unquote good deals and his compulsion to purchase the items. However, there is a fundamental problem with using the word obsession in this context because the DSM-5 defines an obsession as recurring or persistent thoughts, urges, or images that are intrusive or unwanted. This is in accordance with APA 2013's publishing of the DSM-5. Now, the issue with that is that Ryan actually enjoys browsing stores and finding good deals, therein indicating that his thoughts about his obsession are actually enjoyed and not unwanted. Considering OCD's criteria, Ryan is in dire financial straits and resorting to illicit acts to engage in his addictive behaviors. The symptoms do not appear to be caused by the physiological effects of a substance or any other medical condition, as per the criteria found in the APA's 2013 printing of the DSM-5. However, there is a need for more information regarding health and substance use to definitively determine that the previously mentioned criterion applies. There is not enough information to determine that Ryan meets the criteria for having symptoms that are not attributable to other mental disorders. Obsessive compulsive disorder does not have a severity scale. It instead has a specifier of the degree of insight the individual possesses. The degree of insight is difficult to determine in this case due to the nature of the proposed obsession. Because there was no information alluding to Ryan possessing any knowledge that it is unnecessary to purchase everything that is considered a quote unquote good deal, the degree of insight assigned would be with absent insight or delusional beliefs. Where the addiction diagnosis we would give Ryan is compulsive buying disorder. If there had to be a diagnosis given using the DSM-5, one possible diagnosis would be obsessive compulsive disorder with absent insight or delusional beliefs. These are my references, and this concludes my presentation on shopping addiction, the case of Ryan.